Hello, everybody. Welcome to the Pilates Hour. We have a big group today, so excited to be with you. And it seems like we're all interested in pain, or we all have pain. I know that I have my share of pain. While we're waiting for the last few people to sign in and get situated, I had my last pain episode building a chicken coop. A lot of you know I live up in North Carolina now, and I was helping Lizette doing some framing, and I bashed my head really hard into a metal beam, and you know, had to go through this process of thinking, am I feeling tissue damage, or is this really in my head? It was in my head. It was on my head. Anyway, that's what we're going to be talking about today, and I think we're ready to get started. So today our theme is understanding pain, and I think this is important for us, whether we are people who are suffering from pain or working with people that are in pain. Um, why is it such a main focus point in our lives? And how is it that we sometimes tend to drive all of our decision making as physical therapists and Pilates teachers and patients based off of pain? And what I mean by that is, you go to the doctor and the doctor says, where does it hurt? Or you go to the physical therapist and the physical therapist says, so where's your pain? And or you go, I'm going to the doctors because I have a pain. And we use this so readily in our culture. And so I want to talk about it and bring some of the latest science. We got a lot of material to cover, and let's see what we get through today. We'll definitely entertain any questions you have as we go through, if I can answer it. So where do we find the cure for pain? We have become a pharmaceutical society. I don't know if you've noticed or not, but one of the leading causes of death is suicide and overdose with pain medication, particularly the opioids. And they've been our primary source of pain management for many decades. And just now are we really getting savvy to understand that we might not even need opioids when we go through some of these these more major surgeries or severe pain. One of the things I realized last year, this time, I had my hip replaced, and we went through the protocol without any opioids. So I thought that was pretty cool that we were able to avoid opioids altogether with a total hip replacement. That years ago you would have thought that that was the primary protocol for controlling pain after a major orthopedic surgery. I also bring your attention to the picture of Shelley and I 100 years ago doing Pilates on the trapeze table, and just realizing that we have so many people that come to us in Pilates and yoga, physical therapy, that actually get relief from pain when they have successful movement. And so we're going to be looking at, we understand the causes of pain and we understand where pain comes from. It's going to be so much easier for us to really work with it and to understand it, to embrace it, not necessarily to make it our enemy. So I'm going to be drawing on some research, and some of you have heard me talk about some of these individuals before. Lorimer Moseley is one of my favorite. David Butler, I've known for close to 25 years. Adrian Lowe is here in the United States, also very well known in his work of education about pain, which we'll be talking about. So topics of things like false positives, how is the pain coming from the tissue or the brain, and how do they work together? Purpose of pain. Why do we have pain? And then looking at how the pain manages the brain. And then we'll finish up doing a little lab experiment we're going to try today online and see if we get your participation with it and see how that goes for us. So when we are looking at this idea of false positives, I think this is really important. A false positive is when something shows up as being a pathology, but there's really no symptoms. And so and then we have people that have symptoms but have no pathology. So if we look at some statistics, chronic pain has been increasing readily over the last 20, 30 years. And right now they've said that just in the last 15 years in the United States, chronic pain numbers have doubled. And in the UK, they're up 35% or 35% prevalence of chronic pain in the United Kingdom. So That's saying that 1 out of 3 people is dealing with chronic pain as an adult, and that's a really, really high number, right? So, this is getting to be epidemic in nature, and here we are in a pandemic, but epidemic in nature that 1 out of every 3 people is going to be having severe complaints of chronic pain in England. When we look at this kind of numbers, and again, my dissertation was looking at chronic low back pain years ago, and we knew that there was probably somewhere around 80 to 90% of adult Westerners would experience a major bout with low back pain, and that of those, 25% would continue to have low back pain or reoccurring episodes of back pain throughout their life, and that the cost, even in 2005, of low back pain in the United States was somewhere close to $380 billion. So it's like an enormously outrageous number of cost based on back pain. So then we look at studies like this, and they make us go, what's going on here, right? So this study was done where they looked at, I don't remember the exact number. I think it was in the thousands of adults, and they did MRI of people who did not have back pain, who were not complaining of back pain. And they looked at a number of pathologies. Over here you can see in the purple was a facet arthropathy, so that'd be like arthritis of your joint in the back. The green is a disc bulge, and the orange is a disc protrusion. So protrusion is what we typically classify as a herniated disc. This is where the disc tissue is pushing out, typically into the foramina or the space where the nerve root is, and it puts pressure on the nerve root, and subsequently we would have pain down the leg or severe pain right where it's at. So this is really interesting, right? So we're going to look at this chart, and then we have the ages off to the left. So it's saying that 20% of 20 to 29-year-olds, so 1 out of 5, has herniated disc, and they don't even know it. They have no symptoms. And we get up to the age of 60, 40%. That means almost 1 out of 2 adults over the age of 60 are suffering from herniated disc but don't know it. They have the pathology, they don't have any symptoms. So let's take a look at a common diagnosis when a doctor says, your arthritis looks like that of a back of a 90-year-old, right? Well, arthritis is just part of living. I think if we look at these numbers and we see, look, 20 to 29-year-olds, 1 out of 2 people has significant arthritis in their facets by the time they're 29. And that number goes up and escalates very quickly, that those of us that are even our 50s and 60s, it's 100% of us. So it is arthritis in the spine indicative of low back pain? Even if people who have the same arthritis have never had back pain. And, is that disc part of that or no? And these are kind of questions that we ask ourselves looking at chronic low back pain. We get a diagnosis from a doctor, a therapist that says, you have arthritis of an 80-year-old, you have herniated disc, you have bulging disc at L4, L5, L5S1. And we sink that information into our head and into our body, and we embrace it and we embody it. And we start to become that L4, L5, L5S1 disc bulge. When in reality, it has nothing to do, in many cases, with a low back pain. Now, I'm not saying that these back pathologies don't relate to pain. I'm saying they can. But I'm saying there's such a high number of people who have never had back pain, who have these same pathologies, that it makes us ask the question, is my back pain, or is the back pain of my patient really coming from these pathologies that are diagnosed by MRI or something else? And that is a great question, because we don't have the answer to it yet, but we're getting close. We're starting to understand pain better. Now, there's many other examples. There was a study, multiple studies done, where they looked at herniated disc, and it showed 40% of people with no back pain had bulging disc. So again, multiple studies showing this same kind of thing. It also showed over time in a study in Japan by Yukawa that the disc bulges were absorbed over time. So you can look at this pre and post disc bulge and see that, that there's pre and post absorption. Like there's the disc has either rehydrated or it's been absorbed back into space. but it no longer is putting pressure on that nerve root like it was. So there is a sense that the body can also heal itself over time if we're patient enough. Here's an interesting study. This was looking at demolition derby drivers. Now, when I present this slide around the world, or even other parts of the United States, people are like, why do people do this? But this is a favorite pastime, I think, in our, central states and southern states, where you get into a car, you strap in with a special seat, you put on your helmet, and it's sort of like bumper, like a bumper buggy kind of thing you do at the fairgrounds, and you bump into each other, except now you're in a car that actually has lethal forces, and you just keep banging into each other until there's only one car left that's not demolished. And they're the winner of Demolition Derby. But they did a study and they looked at this and they were really fascinated with the fact that the average number of crashes per night are 52 crashes, that they either get hit or they hit somebody else or they get sandwiched between two cars, that they have 30-night career average. That means that they have had somewhere around 1,500 equivalent car accidents in their life for fun in this competition. Yet their incidence of low back or cervical pain is like 2.5%. And so you have to ask that question again, like, why does somebody who engages in 1,500 motor vehicle accidents have a 2.5% likelihood of having neck pain, when those of us in the rest of the world, if we get in one car accident, we have an 80% chance of having neck pain. So one accident equals neck pain, 1,500 accidents, 2 in 100. So again, thinking of, well, 1, they like it, 2, they're prepared for it, 3, they're wearing a helmet and probably a neck guard, but still 1,500 accidents and only 2.5% incidence. That's pretty wild. So let's go to the next slide. Here's another one looking at knees. This was an MRI study done on people who had problems and complaints of pain, and they matched people who didn't have complaints of pain, but similar ages and demographics. And if you look at this, this is pretty crazy as well. So we see that, of the group that was evaluated, equal group of matched subjects, those that had pain and those that didn't have pain, and comparing the lesion to it. So if you start at the top, osteophytes or bone spurs. So there were 77% of the people that had pain had bone spurs, and 72% of the people that didn't have pain had bone spurs. So you have to ask yourself, did the bone spurs cause the pain, or is bone spurs just part of natural degeneration or osteoactivity in the bones and the joints over time? Here's one, cartilage damage. So cartilage damage to the head of the femur, maybe to the base of the tibia, and 72% of those that had pain had cartilage damage. 68 of those that didn't have pain had cartilage damage. So again, it seems that normal wear and tear does not necessarily seem to have the relationship of what causes pain versus what doesn't cause pain. Bone marrow lesion. This is when the cartilage is worn away and there's even more damage that's done to the underlying bone. Things like cysts, subchondral cysts, synovitis. What I found interesting is go down towards meniscal lesions. And it actually turned out that people who didn't have pain had a higher incidence or prevalence of meniscal lesions than those that had pain. And ligament lesions were almost identical, 9 to 11. So this starts making us again ask the question of, where does pain come from? Is this really about the tissue damage, or is it about the interpretation of tissue damage? Again, we can look at shoulders. This is a study looking at the age group of 50 to over 80. Found evidence of rotator cuff tears in 23% of patients that did not have symptoms. So again, we often say, oh, if you're getting over 40, 50 years old and you're an active male or female, you're probably going to have rotator cuff tear and lesions. Here it's looking at 23% of adults over the age of, from 50 to 80 are experiencing rotator cuff tears, but do not have any symptoms. And so again, the question is this really a problem of the symptoms, or is this something else? I'm looking at professional athletes. When we look at the basketball players of the NBA, 75% of them return to play after they've had a microdiscectomy or lumbar surgery. In the NFL, the football players, 78% of them return to play again after a back surgery. But if you looked at our normal population and you said, what percentage of them return to physical labor after a back surgery, it's probably going to be somewhere closer to like 20 or 30%. So we asked the question, why is it that the elite athletes are more likely to return to their work? Well, the first one becomes obvious. You say these are really conditioned human beings, and they're going to recover faster, maybe better blood supply, maybe they have a natural propensity to heal better and to tolerate these kinds of injuries better. But you could also say they have a really huge motivation. The motivation is that they make so many hundreds of thousands of dollars per game, and if they don't show up to the game, they don't make the same amount of money, and they only have so many years they can actually play in the sport. So does the motivation to get back on the court or the field have greater impetus for them to be able to return to work than, say, somebody who is a laborer in a city job or working in a warehouse? I think there has to be some kind of correlation going on there. So here was an interesting study done, and they basically took these, this is not the exact study, but it was the pictures I could find of it, but they took these students from the psychology course, always from psychology courses in universities, become the guinea pigs for pain studies. And they put them underneath these hair dryers, and they told them, because they're so old, we don't use these things anymore. I remember them as a kid when my mom would go to the hairdresser, and said that they were causing migraine headaches. And what they want to do is do a study to see when the radiation of them or the energy of them got to a certain point, when did it start causing a headache? Now, there was no evidence ever of these hair dryers causing headaches, but there was a direct correlation with the magnitude of the dial that the students were looking at and the headache that they had. So if the dial was turned up high, there was a higher incidence of headache. If it was turned down, there was lower. And there was no energy. There wasn't even air blowing. They were so unfamiliar with it that it was just the head things themselves. They looked like they were turned on, and there were dryers, and there was a direct correlation with the bogus knob and the severity of the pain. This was a client of mine. We'll call him Jack, even though his name wasn't Jack. But Jack had come to me and had a significant protrusion. So if you look at this disc here, down at L5S1, it's really all the way out into the canal, right? And you can sort of see where the red arrow is pointing, and that's pretty significant. And he came in and he had radicular symptoms down his leg. So he had a loss of strength in his foot, and he had some paresthesias in his foot, and he couldn't lift up his big toe, and a little bit of a drop foot. And those are all things we would consider as neurological signs and symptoms. And so we started working with Jack, and we started doing some Pilates and some physical therapy, and he was doing better. We got rid of the symptoms down the leg, which meant that the inflammation around this disc was decreasing, even though we didn't do anything to change the disc herniation at the time. So he finally got permission from his insurance company to go get his MRI. So Jack comes to me and he says, "Hey, Brent, should I get my MRI?" And I said, "You've already centralized. It's probably better we don't have those kind of images in your head. I would avoid having an MRI unless you're having bowel and bladder problems or the pain down the leg doesn't get better. Then we can get an MRI." So he did what all my patients do. He went ahead and he got his MRI, and this is what his MRI showed. And when the doctor was showing the MRI, he drew this, circle around his actual physical MRI back then. And he said, "Jack, I haven't seen a disc hernia this bad. It's a miracle that you can walk," right? So now all of a sudden, Jack comes back to physical therapy, dragging his right leg behind him with his MRI films in his left hand at that time, not a CD. And I'm like, "Jack, what's going on?" He goes, "I got pain down the leg again. I got symptoms." And I tested his neurology, and it was fine. Reflexes were fine. Strength was fine. No drop foot. I said, "When did these symptoms start up?" And he says, "Oh, it started up when, the doctor talked to me about the MRI results." I said, "Oh, so you got the MRI, obviously, in your hand." He says, "Yeah, the doctor said that's the worst disc herniation he'd ever seen, and it's a miracle I could walk." So I called the doctor up pretty quickly. I'm like, "Hey, I won't say his name, but Dr. So-and-so, Jack came to me today and he said you told him such and such." And he goes, "I did, but I told him that he wasn't surgical, he didn't have any neurological signs, that he'd get better with his physical therapy and Pilates with you." And I said, all he heard was that's the worst disc herniation I've ever seen, and that it's a miracle he can walk. Today, he's manifesting symptoms. And it took us about 6 months to get Jack convinced that he was fine and that he could participate and return to activity, where I was convinced that if I could have gotten Jack back to, without him having the influence of that MRI, I could have probably had him back in a matter of a month or two, being able to participate fully in his activities. So again, sort of this hypothesis of how, the image in our head, right? Jack seeing this picture and seeing, not fully understanding it necessarily, but seeing this picture and going like, oh my goodness, I have a disc herniation. It's the worst disc herniation this doctor's ever seen. And he thinks it's a miracle I can walk. Oh my goodness, my leg's starting to hurt, right? So this kind of scenario. So pain doesn't provide a measure of the state of the tissue. This is really important to understand. It does not measure tissue trauma. The pain system is not a very good determinant or damage meter, but that is not its purpose. This is where it's really important for us to understand. Moseley said the important task is to break the image information down into a meaningful component and thereby perceive the need for action. So when the body, the peripheral body, tells us information through the nervous system, the brain has to interpret that information and determine, is there a threat? Is this dangerous to me? Do I need to take action, right? In and of itself, it is not a pain meter, right? Not a damage meter. This is a story that Lorimer Moseley told, driving, out back. He was hitchhiking and he got a ride with a guy that had below-knee amputation, had a prosthetic limb, and was driving. And as they were driving, he got uncomfortable. He took the prosthesis off and he put it in the back seat and continued to drive. And they get to the area where he had had his accident, that he lost his leg between a car and a train, and he had lost his lower leg. And all of a sudden he starts having severe pain. And Lorimer Moseley tells the story best, but that the idea that he said, please give me my leg, and he gave him the prosthetic leg back. And he says, can you get like a butter knife out of the glove box? So Lorimer gets the butter knife out of the glove box, and he says, can you take the shoe off of the leg, the artificial leg, and poke this, butter knife into the hole that he could see was happening. So he's having these phantom pains. There's no real pain down there. He's having the pain up here, but he feels it in his foot, right? There's a common phenomenon called phantom pain. And Lorimer is like jabbing this butter knife into this hole in his wooden foot. And he even tells him, can you get out of the way so that I can see you putting the butter knife into the hole in the foot? And, isn't that interesting that it was about the perception of being able to see it, even though he knows full well that that is not his leg. That is an artificial leg. There's no nerves in it. But for him to be able to visualize the poking into the area of severe pain calmed down his symptoms, and he was able to calm down. The other interesting thing is that it was triggered by crossing the road where he had had the accident to begin with, or the railroad tracks. So vision is very similar to pain, right? And lately we've been talking a lot about the mind setting and how our RAS, things that we focus on, things that we see, and pain is very much like this. It's a very complex process. It's not just sensory input. We can walk into a room and we literally capture all of the light, all of the reflection, we see everything, but we only make sense out of things that make sense to us. So it's not a given that that's how it's going to work, right? So based on the brain's perception of how much danger is present, we identify what we see, what we feel, what we observe. And pain depends on the unconscious interpretation of a potential risk of damage to the tissue. And I say unconscious only that you're not thinking about the interpretation, but as soon as the interpretation identifies it being dangerous, the consciousness is involved. So when you think of drugs like amnesia drugs for surgery, when you do anesthesia, right? General anesthesia is an amnesia drug. It does not mean that the brain does not receive nociceptive input coming up from the area of the surgery. It certainly does. It's just that we don't remember it, but it imprints in our body, and there is a memory. So when we come out of the anesthesia and we start feeling the pain, sometimes that pain is worse. So I'm going to go back to the previous story, and I think Rosanna asked this question and interested about how do we avoid opioid treatments for these types of surgeries, right? Well, what happened was if they do an epidural or a block before surgery, then those nociceptive messages are not getting up the spinal cord into the thalamus and into the brain. So the brain is not having, even though it's unconscious, is not having this stimulation coming in that is causing chemical changes in the thalamus and the other unconscious parts of the brain. Versus, and then when by the time you come off of the local anesthesia, the Marcaines and those kind of things, that the severe pain now is no longer coming up into the central nervous system. So the central nervous system does not have to process what it experienced while it was unconscious. It now just has to process what it feels when it's conscious, where sometimes something as easy as an anti-inflammatory or Tylenol, or even a limited amount of opioid, like slipped my mind. Anyway, a small limited drug, right? So the amount of drugs instead of having to go with the really strong opioids. So this is where vision is very similar. We see what we're going to see, and I always make the joke that I come home and I like to have my bubbly water, and I have the bubbly water in the refrigerator, and I come home, I open up the refrigerator, I'm looking through there and I don't see it. I know I just bought some, and I bend my knees even, because I'm told sometimes I don't bend my knees being tall to look and see if it's maybe on the upper shelf in the back, but I bend my knees and I don't see it. So I call out to Lizette. I'm like, hey Lizette, do you know where the bubbly water is? She goes, it's in the refrigerator. And I'm like, no, I'm in the refrigerator now. And then she says, bend your knees. I said, I am bending my knees. And I said, I don't see it. So she comes walking out from the back room, and the first thing she finds is right in the front of the refrigerator is a 6-pack of La Croix. So again, it's not just that I'm a guy. It is more important that I just didn't see it because it didn't make sense to me where it was in the refrigerator. It was in a different place. So we see what makes sense to us, and we process pain that makes sense to us. Very similar process, very interesting way that we are able to understand things. Here's something to do with perception. So if we look at these two lines, line 1 and line 2, and you had to make a decision as to which line is longer, right? Would you choose line 1 or line 2? Or is it possible that the two lines are the same length? It's just the arrows create a change in perception, where line 1 and line 2 are exactly the same, right? But they appear to be different, right? And so it's the appearance of. In the mind setting, we talk about the RAS and the things that we're able to see or process. And when we go out and about and looking, to buy a house, we see every house for sale sign that's in the area. If you're looking to buy a new car, you're going to see that certain kind of car. If you're expecting your first baby, you're going to see every pregnant woman in the county and everybody that pushes strollers, or any ads that are out there for baby food or baby clothes, you're going to see. So pain should motivate us to take action. This is really the purpose of pain. It doesn't tell us how bad something is, rather it motivates us to do something to protect tissues perceived to be under threat. That's its purpose, and it's good and it's healthy. And we should appreciate pain. When the brain is satisfied, it stops creating the experience of pain. This is what explains placebo. I often have a little bottle of medicine or something somewhere, sometimes like a NSAID or something like that, in my office, and I don't really want to take them because I don't like how they make me feel, my stomach, I avoid them. But the fact that I know if my arthritic soreness doesn't go away by midday, that I could take that pill and feel better. Well, the funny thing is when I get in the office and I'm hurting, but I see the bottle or I see the pill, I immediately feel better because I know there's a solution if I need one. And so a lot of times this is where you go to the doctor, you've been hurting for a whole week, you finally get an appointment, you go to the doctor and the pain's gone. Well, the pain's gone because the brain is satisfied that you are going to solve the problem. It's not that there isn't still an inflammation or that there still isn't a nerve impingement or there are other problems, but it's just that the brain goes, hey, they're finally at the doctors, they're going to get better, right? So as we go to the doctors and we feel like we're going to get better, there's no reason for pain, and pain disappears. Sometimes it disappears, but if the treatment doesn't make a difference, all of a sudden the placebo wears off and the pain comes back. So this is a story I picked up in the news of a woman in Moscow that got mugged. She got stabbed in the back of the neck but didn't know it. She escaped from the mugger. She ran to her parents' house a couple blocks down into their apartment complex, and her dad realized that she had a knife sticking out of her neck, a pretty significant knife. They took her to the hospital, and when she arrived, it was like not knowing that she had a knife sticking in her neck. This is a common thing. I remember being in the ER one time, and a guy comes in that had a hammer claw stuck in his neck, blood squirting out. He's a carpenter, and he was casual as could be, had a cloth on it, holding it. He signs himself into the ER. Everybody's a little horrified by the amount of blood and the fact that he's got a hammer sticking out of his neck. He turns around, he hits his shin onto a little coffee table in the waiting room of the ER room, and he starts screaming bloody murder, that, pain and ouch and ooh and all these kind of things, and who would put a table there, and jumping around grabbing his shin. And we're all looking and going like, dude, you got a hammer sticking out of your neck and you bump your shin, you feel more pain with the shin than you did with the pain in the neck. That doesn't always make sense. This is an example of what I had. When I was in 1980, I went up with some friends into the canyon, the Feather River, just outside of Sacramento and up towards the mountains area. And we love to go cliff diving, particularly in this spot, right? So this is a year after I had had an incident where I had jumped off a cliff and I had actually hit my head on a rock. So, if you think that I'm smart now, I think I would have been a lot smarter if I hadn't hit my head so many times. I keep hitting my head. Anyway, I had a horrible incident there, and I don't remember hardly anything of it. Somehow I miraculously was able to get out of the water. My buddies pulled me up the side of one of the cliffs. We had to hike out 5 miles. I remember seeing the license plate of my truck and laying in the back of the truck. They took me to the ER room. The next thing I remember was the doctor looking in my eyes. And I don't really remember anything for a week or two after that was due from a concussion. So the body also has a way of eliminating that. I don't remember the pain of that incident. I don't remember the headaches that I'm sure that I had. Other accidents in pole vaulting where I've hurt myself pretty bad, and fracturing bones, just those going to shock. The body has ways that it also protects us from excessive amounts of pain when there's severe trauma to tissue. So pain is designed to protect us. And there are certain types of misinterpretations of pain that exist. Overzealous athlete is one of them. That's sort of like the show must go on, or the ballet dancer that tapes up her leg and she goes out and dances anyway, even though she has stress fractures in her tibia and her fibula. So they're basically suppressing the signals by a motivation higher that's coming and saying you have to succeed. You have the patient who really doesn't care what is wrong. They've sort of detached themselves. So this is often somebody I find that has either had some kind of abuse or disconnect or trauma in their life that they've said, I don't feel anything down below here, so you see them just, it's not going to bother me, right? And then we have those that mask the pain, and so they hide it, right? They have the pain, but they hide the pain. This is sort of like, our mothers and aunts who, are suffering, and they want to take care of everybody else. How are you doing, honey? And it's like, I'm doing fine, but you don't look very good. I'm fine, right? And, they mask it. They try to suppress the symptoms that they're having. So that also is a faulty interpretation. If we listen to it, we embrace it, we identify it, and then we find a solution to it and understand, is this pain one that can cause severe trauma over time, or is this something that is not going to cause severe trauma over time? It's more of an interpretation problem, which we'll talk about in a minute. And then the last one that we see probably the most common is people just stop doing certain activities. You know, it hurts to walk, I quit walking. It hurts to squat, I quit squatting. It hurts to pick up my grandkids out of the bathtub, I quit picking my kids up out of the bathtub. So we see people come to us as Pilates teachers and physical therapists, and they're asking these questions. They're saying things like, hey, you know, I haven't been able to go walking for a long time, or I haven't done these things. It's like, why? Well, I started having pain and I just figured I would stop, right? So now we got to go back in and figure out, can we create a walking experience that isn't causing pain? Can we minimize the interpretation of the pain that they're experiencing? Just a couple of books here that from Lorimer Moseley and David Butler, some really good books and literature, and of course we'll share this with you afterwards. I don't make any money off of referring these books. I've enjoyed them myself. I think The Painful Yarns is my favorite, and Lizette and I have laughed to tears reading Lorimer Moseley's encounters in Painful Yarns. So if you want a good laughing read, but also really bringing home this idea of where does pain reside. And then David Butler's book on Explain Pain is probably one of the most standard books that's out there that just really has a clear picture, especially for our clients and our patients. Like if you're listening to this webinar and you're a client or an individual that's suffering from pain, these are great books to read because they're designed to educate us on how to understand pain. So when we look at the brain, the idea of pain becomes very complicated. A lot of times we don't understand how multifactorial we are as human beings and what this even means. So in the human brain, we could think of acute pain being involved in multiple centers around the brain. It's not like there's just one pain center. So we talked about the thalamus and the pons and the prefrontal lobes and the different cortices and the parietal lobe, which is the historian. And all of these are related to that one information coming up of, or historically coming up of pain. So if you think of distraction, right? Distraction can decrease the number of sites that are firing off in this painful arc of, you know, like a burned arc, electrical arc in the brain. And every time that we reproduce the painful arc, it becomes stronger and stronger and stronger, and we end up with that phrase, what we fire, we wire, right? So the more that we fire this thing up, the more we think about it, the more we talk about it, the more we focus on it, it gets hotter and hotter and hotter. The pain starts persisting. Now, maybe the tissue trauma that happened a couple of weeks ago is long gone, but we've had such a fanaticism inside of our brain of dealing with this pain that it has gotten hotter and hotter and hotter, and creates its own chronic problem in and of itself. So we look at factors that influence making that pain hotter, right? So again, it's normal to have that imprint in multiple areas of the brain, but it's not healthy for us to continue to exacerbate the pain through our mentation, through our thoughts, through our regurgitating it, through our emphasizing it. And so you might ask, well, where does that happen? Well, the brain remembers previous experiences, right? We go through this little circle here of pain. We have sensory input, things we see that are tied to that painful event. I looked down, I saw the bone sticking out of my shin, right? Yeah, I got that picture in my head. I saw that. Or I saw the x-ray or the MRI, and I saw the herniated disc or the fused bones or the stenosis the doctor pointed out to me. There's also cultural experiences. So in every culture, it's a little bit different, right? Even socioeconomic levels can make a difference in our social environments of how we perceive or interpret pain. It's very easy to be caught up in, a party of complaining about who has the worst injuries and the worst pain. This is why when people come to me with chronic low back pain, the first thing that I tell them is I'll treat you on 2 conditions. Number one is you can't belong to any kind of social, pain support group. And they sort of look at me like, that's sort of a weird request. It's like, yeah, it is, but if it was something else, I would say go for the support group. Alcoholism, drug addiction, loss of loved ones. Those are super important support groups. But pain support groups, these people often end up getting into what we call, pardon the expression, but a bitch fest, where they're just complaining and complaining. My pain's worse than your pain. What that does, if we go back a slide, right, we're just bringing more attention to that wiring and firing that's going on inside of our central nervous system. It's no longer associated with the tissue, theoretically, in the peripheral body. Now it's just in the central nervous system firing away. Beliefs and knowledge and logic also are major factors that influence pain. We know that people who believe they're not going to get better don't get better. People who believe they're going to get better, get better. It's got like a 78 correlation with fear avoidance back questionnaire, with self-efficacy scales. It's very powerful what we believe. The other thing is the expectation. So as soon as a client jumps into the website and looks up, what does fibromyalgia mean? And they start reading all this literature on fibromyalgia. This is what the Mayo Clinic says. This is what Boston says. This is what, right? And they go through and they read all these things. And you start creating and forming your own situation. This is the same thing with, for example, cancer diagnoses. One of the things we suggest people to do when they have cancer is, once you've identified your team of all-stars, right? Who's the doctor, the nurses, the surgeons, everybody that's an all-star. Deepak Chopra talks about this as well, is that you now just focus on being as healthy as you can be and leave the medicine and the prognosis and all of those things to the professionals and the team that you trust. Don't keep looking for new teams. Don't keep getting distracted, because all you're doing is creating more and more negative energy, potentially of doubt and distrust and fear, that all diminish the immune system and the response to the intervention you're going to receive. They've shown actually statistically that people who buy into their treatments, and particularly in cancer treatments like chemotherapy, and they feel that they resonate with this. I think it was Alexander Bolander talking about this in the workshops. If you got a chance to be in the Polestar Experience Saturday, Alex was talking about this and showing that people who resonated with the intervention, like they respected their team, their body felt like this was the right thing, had a much higher and improved outcome and response to the treatment. If you feel like the treatment is wrong for you and you don't feel that resonating with that doctor, that person, then you're creating more of a negative environment for that to happen. Well, it's no different in pain, right? Pain is a residual effect of many different types of pathologies and injuries. Expectation about the consequences directly affect the outcome. So if we can improve our expectations, if we become educated, understand what is pain for, why is pain manifesting now, is there tissue damage, is there any action that I need to take, does my social environment impact it? Is somebody coming up to me that is an enabler that keeps making me remember and think about, how are you feeling today? How's the pain in your left eye today? Well, I didn't really have any pain in my left eye until you asked me. Or the physical therapist that says, is your pain hot, throbby, sharp, dull, achy, pinchy? And the patient started going like, yeah, it's all of those things, right? Well, if we were just patient and we asked our clients, well, what do you feel? And they sit there and they think, I feel tension. Okay, tension. Interesting. Let's take a look at tension. Let's see what's causing tension, rather than me putting a whole bunch of words in their head saying, so where do you feel pain? They have to go through their head and go, well, I actually didn't come here for pain. I came here for tension. Right, got it. Now they're thinking, do I have pain? Maybe that tension is pain. Maybe that's what I'm feeling, right? So you sort of get the idea. This is a very powerful wheel when we ask ourselves, what's going on? What are the factors influencing it? The biopsychosocial, so this is Adrian Lowe's work, and he says what a patient thinks, feels, and believes about his or her condition will significantly impact their examination, treatment, and prognosis. That's really powerful, right? So what we think, what we feel, what we believe are just as powerful influencers as the physiology of the disease or the injury itself. Very powerful. I've already talked about anesthesia. This is some of Sarno's work too, and I know somebody, I think it was Sarah, said talking about John Sarno's work and what it meant to her. And Sarno, was one of the leaders in understanding the psychosomatic aspect of pain, and realized that pain or belief or fear could influence things like blood flow, motor output changes, immune systems, autonomic systems, and that if we treated pain in one part of the body and we didn't deal with the psychosocial element of it, it would manifest somewhere else, and it just keep manifesting until we were able to really deal with the problem at hand. And I have many stories that I like to share that I'm gonna not share right now because we don't have time, but countless stories of people who perceived their pain was from a diagnosis of pathology, but when they really asked the questions, they were things that were tied to relationships, to beliefs, to financial stress and other elements, communication from their doctors and therapists and Pilates teachers that told them they had scoliosis for the first time. They'd never heard of scoliosis before. So research supports the neuropsychology education, and this was from Adrian Lowe as well. And this is probably where I'm going to stop for now. And this is where he said that the chronic musculoskeletal pain disorders, there is an education strategy addressing the neuropsychology and neurobiology of pain can have a positive effect on pain, disability, catastrophizing, and physical performance. And I think this is always fascinating to me as well, because if I can educate my clients, if I can educate myself, if I can educate you and understand the sort of neuropsychology and neurobiology, that I can really make a big difference and feel a lot better. And these are some of Adrian Lowe's books that I like to post up here, and again, we'll share those with you. Some of these are books like your fibromyalgia workbook. I obviously don't like the name fibromyalgia because I think it is it's a little scary. But it is a fantastic workbook for people that are dealing with chronic musculoskeletal pain. And then the book, Why Do I Hurt, is a great book that goes to the client. And then for me, I have found a lot of great answers and great information in the therapeutic neuroscience education from Adrian Lowe, that this book is more for the practitioner, so the Pilates teacher or the therapist to read this book. I do want to move forward into one or two slides ahead here, because I want to talk about this lab, and this is where we'll finish up today. Adrian Lowe talks about the lion within, and you might think of, well, what does this analogy mean and where is it going? So the lion within is really talking about things that spur the wiring that we were talking about inside of the nervous system, right? Inside the central nervous system. So a couple of things that I've noticed for myself is that for me, if there is a financial or a relationship issue in my life, my pain perception increases. And when I can spot that and I can go, oh, I thought I had to fire somebody or let somebody go, or I was having some other relationship issue with human beings, of things that I really don't want to confront, conflict, that I actually noticed that my symptoms increased in my low back or in my neck or in my knee or my hip. And then I also noticed that when there was financial stress, so like going through COVID and thinking of all these things, that in and of itself also significantly increased the symptoms. When I could spot it, I could identify it, I could minimize it, and as Adrian Lowe says, turn that ferocious lion into a little kitty. So I'm going to have Melissa help me out. I'm going to have her put up a poll And I want you to think, in yourself, what are things of the lion within you? And let's just see how we're doing with this idea. What's the lion within you? Is it fears and anxieties? Is it relationships or job issues? And of course, you can vote for more than one if you're somebody like me that has more than one issue that influences my pain, and money concerns or others. So take a second, just click on the ones that fit you the best, and then we'll have Melissa bring it back up for us to take a look at, to sort of see how common it is for us to have emotional lions within us that actually exacerbate our pain symptoms. So take just another 30 seconds, and then we'll have Melissa bring it back up and show us how we pulled out today. And I think we have well over 200 people on the actual webinar, and we had almost 600 people sign up for it. So this has been a great, I guess, of interest. I hope that I'm doing it service. All right, Melissa, let's bring up the poll and see where we're at. All right, so it looks like 68% were fears and anxieties. Money was number 2 in a close second place of almost 50%. Relationships 38 and jobs 26. So let's return to the slide for a second. Isn't that interesting? And when you think about it, the majority of us really do, have this idea of fear and anxiety that tend to be directly related, where 50% of you felt that there was a relationship to fear and anxiety. And one of the things that we want to do in Pilates, and this is where we'll open it up for questions now, is how do we create positive experiences of movement when the fear and the anxiety is directly linked to movement? So when somebody comes to you and says, I'm afraid that if I step the wrong way, my ankle's going to sprain, or I'm afraid if I go for a walk, my back's going to hurt so bad, I won't be able to get back to the car or to the home, right? So these are legitimate fears. There was a study done recently out of Washington University in St. Louis, and they had, I want to say it was like 200 people that they had in the study, and they had them stand still, and they had to stand still for an hour, and 100% of them had low back pain after standing still for an hour. But they also did a fear assessment and fear of a back pain assessment prior to the test. And those that had really low fear, were not afraid of all of pain, recovered 100% after they had had the back pain from standing. Those that had high fear of back pain actually had to be treated for back pain following their standing exercise for the 1 or 2 hours that they were standing still. So we know, and even in my research where we showed that people's belief, their self-efficacy was a much greater predictor as to whether they would get better or not. And the question is how do we influence belief? How do we influence fears and anxiety as Pilates teachers? And I think one of the greatest ways that we can do that as teachers is to create positive movement experiences without pain. Well, how do we do that? We do that by using the environment that gives us assistance, right? We can vary load, we can create foreign environment, but more importantly, we can change the way that we talk to our clients. We need to talk to our clients in a way that we are not the problem ourselves. We're not throwing out diagnoses and prognoses. Rather, we're asking them, so what were you able to do yesterday? Do you feel like you're getting any stronger? Do you feel like you're able to do more? Rather than asking, how's the pain today? Is your pain any better today? So avoiding things like the pain talk and really focusing more on function. The last thing, I see some questions coming in now. The last thing that I'll share with you is I sort of recreated a pain scale. We typically have the 0 to 10 pain scale, where 0 is no pain and 10 is intolerable pain. And what I do is I ask the client, what are they able to do? So for example, I might say, yesterday, were you able to do everything that you had planned to do yesterday? And they say, yes. So even if they complain that their pain was severe, I have my own little scale that they cannot be more than a 4 out of 10, meaning that no matter how bad the pain is, if they're able to do all of their functional activities, they're a 4 or less. If they can't do 25% of their activities that they wanted to do, they're a 5. If they can't do 50%, they're a 6. If they can't do 75%, they're a 7. If they can't do 100%, they're a 8 or a 9. And I really keep 10 for those that had to go to the hospital to be able to have some kind of pain control. So there has to be some kind of severe level of pain that is measured. And what I find is that the majority of my patients, even in severe pain, are hovering around 3 to 6. So that it's a matter of more of them limited in their functional activities during the day. I think that's super cool for me. I always like to think of that. So let's take a look at some questions here. I have John said, what about those that seem to feel more pain than the injury would suggest? And John, you know, this is what we deal with every day, right? So the question is how do we align the perception with the reality? Is their pain really so severe that it completely disables them? And is that pain related to a tissue problem, or is it more related to anxiety and fear, right? So as we go through this process, you certainly don't want to go to them and say, I think this is in your head. I think this is all an anxiety program. You need to see a shrink. That's not a good approach. But what I do like to take as an approach is, how do I create these positive movement experiences for them that they have to ask themselves, isn't it interesting that I could do that movement and I didn't have pain when I was working with John? Right? That's a really powerful statement for them. Now, people who have been dealing with chronic pain for a lot longer, and chronic pain, remember, doesn't necessarily tie into always having tissue damage, right? It could be an inflammatory problem or autoimmune problem that do cause chronic information coming in. But we know from human behavior that we can modify those human behaviors. We can modify those interpretations if they are not causing tissue damage, and we can still function. So again, redirect to function, function, function. Sarah, you asked me, what was the second condition you asked of your clients? Oh, very good. So you remember that. So the first one was not to belong to a support group. The second one is that they donate at least a couple hours a week into a volunteer organization, preferably one where people are suffering more than they are. So going in and working in a children's cancer ward, working in a food kitchen, somewhere where they are not thinking about themselves. So those are my two conditions. Sorry, I forgot to bring that up, right? Maggie from La Paz. Hello, Maggie. How are you doing? Thanks for the talks you give and organize. I see you more now than before. The idea that pain is a belief when the doctor diagnoses it and actually turns into pain or illness is very interesting. So yes, we can have things work in both directions. So we can have pain that motivates us to find an answer of why we're suffering. And we can also have diagnoses of things that could exacerbate what we're feeling and actually lead to pathology, can lead to the problems where the physiology actually changes. Right? Bev said, would you describe again what happens in the brain when a pain block has been given? Did you say that the brain does not receive the info, but it is in our subconscious? So when you have an epidural, yes, so an epidural is going to be a block that goes into the spine, right? It's going to be a nerve block. So there's no messages coming up from, let's say, the hip. So I had my hip replaced, right? So they do an epidural in the spine, and it basically blocks all the messages during the surgery from going up into my brain. So my brain does not receive any messages coming from my right hip during the surgery. So by the time the long-lasting marking, usually 24 hours, 30 hours after the surgery starts to wear off, the amount of irritation inside my local hip tissues is so low that the message getting up to my brain is much, much less. And yes, there was some discomfort, but it was the level of discomfort that could be managed with things like Tylenol or with some kind of anti-inflammatory medicine, a little Demerol kind of thing. So it was much easier to manage. And literally within a day, there was no need for any medication other than anticoagulation medication and just sort of managing the inflammation process a little bit from the surgery. So very, very cool process. I hope that answers your question. When you don't have the block and you just have the general anesthesia, the pain signals are going up the spine into the thalamus. It's just that it's not coming into the prefrontal and the conscious part of the brain to be recognized as being pain, right? We couldn't tolerate that if that was the case. So putting us in a subconscious state and amnesia drug, we don't remember it, we don't feel it, but the system was challenged and stressed, and the anesthesiologists believe that when they can manage that better during the surgeries and during the difficult, traumas, that there is a lot less pain in the recovery. I think there's some more research to be done on that, but I think this is cool science. Lisa, great presentation. Thanks, Brent. Thank you, Lisa. Appreciate it. Sheila, once again, tons of great info and knowledge. Thank you. Sylvia, obrigado por tudo. Thank you in Brazil. Sharon, great as always. Thank you, Brent. Adriana says, a bit unrelated, but on the Pilates experience, they mentioned 10 roll downs a day keeps the doctor away. But how about if clients have osteoporosis? Well, I would say, and more likely today, I would say 10 swans a day keep the doctor away, and that's no problem for people with osteoporosis. So maybe shift it from the fact that we're now in a sedentary world and we need to be working more on our extension than we need to be working on our flexion. Might be a good way to move with that. Dr. Miller says, I think one has to trust the knowledge and experience of the instructor. Clients will remain with one who knows their beliefs and physical capabilities. We've all dealt someone in our health circle that isn't listening. And yes, Dr. Miller, you're absolutely right on that. I think that, one of the first things is we build rapport with our clients. And, one of the things I don't ever want to be guilty of is being the one that tells them what they need to do. I really like my client to trust the fact that I'm going to try to give them education and the ability to practice. And I think when I was looking for my hip surgeon, I found like 4 or 5 that were considered to be some of the best in the world doing anterior hip surgeries on the MATA table. They were all trained by the same guy that I really respect out of Colorado now. And yet the thing that was most important to me, and it was the trust, as I sat down with Dr. Juan Suarez in Miami, and he sat down next to me and he asked me questions, right? He asked me what I was feeling and what made me think that I was ready to have a hip replacement. Instead of what everybody else does, they threw the film up and they're like, oh my gosh, how do you walk on this thing? You need to have a hip replacement. It's like, you can be a great surgeon, but your bedside manner sucks. Dr. Juan Suarez really incorporated me, and immediately I had a rapport and trust with him. I knew his track record. I knew he was a great surgeon already. I knew he'd been trained well, but that little bit of trust made all the difference in the world. And we basically approached this in a process together. And today we still talk about it, like, what was your feeling when you had this, or when you came out of anesthesia, or the cocktail that we gave you before the surgery? Very, very powerful stuff. Elaine said, so how does acupuncture during surgery work? Well, acupuncture, we don't fully understand acupuncture, but we know it works. So there are things that have to do with sending different signals. It's an interrupter, right? I mean, nobody likes to have needles poked into them unless they know that it's going to create relief. But it is a nociceptive stimulus in a lot of cases. And so it can be a distractor like electrical TENS. It could also, I think, taps into the fascial system. So I think when you tap into that fascial system, it communicates to all tissues. Fascia surrounds the brain, it surrounds the nerves, it surrounds the muscles, the organs, the skin, it connects everything, tubules filled with light photons. So I do think that there's a lot more that we don't understand about acupuncture yet. We just know that it's worked for thousands of years. And some people can go through and do surgery with just acupuncture, no anesthesia. Let's see, I think we're out of time. I do have 1 or 2 more questions that I'll answer. It says, it looks like Hind, H-E-I-N-D. Sometimes we spell the names wrong, but thank you for asking. It says, when treating a patient, how much of the treatment is neurological, stimulating different areas in the brain, and how much of it is manual or movement therapy? And I know it depends on the patient, but what would be a good pointer into how much to do of each? Well, I think they both tie in together, right? I think, our tool as Pilates teachers and physical therapists is movement. So if we're creating movement experiences that do not have pain or do not increase pain, we then are stimulating the nervous system, particularly the thought system, and belief system of how their body is. And if that belief changes, those threshold of pain also increases. We want that threshold to increase, right? So normal, if you're fearful and anxious, what it does, it drops down that threshold. So normal things of like proprioception and pressure, all of a sudden are interpreted by the thalamus and the parietal lobe and the frontal cortex as being painful. It's not painful. There is no tissue damage, but the brain is interpreting it as being painful. So how do we create the movement experiences that allow them to go, oh, movement, it actually is not so painful. Hind has taught me how to move without pain. Right? Rosanna said, please explain if pain is not necessarily representative of tissue damage, how or when do we determine if there is tissue damage? As Pilates teachers, do we need to know? And the answer is yes, like if you see a bone sticking out of the tissue or those kinds, but typically as Pilates teachers, we're not doing anything that's really going to cause tissue damage, at least not in the lower and medium exercises. I think we're much more dangerous, in other fields of things, that are more aggressive. But that being said, I think we listen. Yeah, we listen and we ask the patient or the client, how does it feel? What do you observe when you do this exercise? And their information, if they go into an area that starts causing anxiety and fear, we've gone too far. We have to modify the exercise to be successful without the anxiety and fear. I think that's really the key issue there to help us out. I'll finish up with Kim. I'm assuming this is my dear friend Kim Gibalisco, but if it's another Kim, introduce yourself to me at another time. Great info, Brent. Can you quickly touch on how breathing and meditation help downregulate pain? This is exactly the point that it's a great one to finish up on here. When we deal with anxiety and fear, we know that it brings the pain up, right? It takes the threshold down, increases the pain interpretation. The anxiety can make us feel like we're having heart attacks and think we're dying and suffocating and literally have physiological changes where blood pressure changes and potentially have a heart attack. I mean, there's people that have been so stressed out. So wouldn't it make sense that the opposite would have a reverse effect on the autonomic nervous system? So how do we get the parasympathetic system to do its job more and to decrease the sympathetic? This is where we talk about, and if we were to continue in the lecture, limbic system versus frontal, right? So Kim's suggestion of things like breath work to slow the body down and meditation to get away from focusing on the pain rather than focusing on something else, right? Meditation is having singularity of focus, preferably away from a pain cycle that we might be in. So we can teach our clients techniques, take them through meditations, teach them breath techniques. Breath can always bring pain down. We use breath all the time when, for example, with childbirth, and breath can help manage pain in partum. So there's a lot more to talk about. Maybe we'll do a part 2 on pain. I know I'm out of time. I got about halfway through my slides. We're going to have some more education happening next week. I'm still debating. I think I'm going to talk about mobility and some of the new stuff I'm doing with mobility out of the book that hopefully will be released in the next year. And then the week after that, Shelly's going to come on with me, and we're going to meet with some of the people who have actually gone through the program of mind setting, and we want to interview them and see how their experience has been. If you're one of those and you'd like to be part of that some way, let us know. Send us an email. But we feel like there's some great work happening out there with the mind setting course. Be safe, wear a mask, social distance, stay out of places that have too much noise and not enough circulation. Perfect storm for spreading disease. And we'll see you next week. And I also was going to mention, if you had a chance to attend the Polestar experience last Saturday, we would love to get your feedback. I'm going to be teaching on the next one in August, so I'd like to get your feedback and know how to make it even more special for you if we can do that. And we'll see you in a week. Have a great weekend.